Good evening, everyone, and welcome to our session on what clinicians want to know, addressing community oncologists' questions about current and future role of antibody-drug conjugates in the management of breast cancer. This is such a hot topic. I think we're all giving antibody-drug conjugates, understanding when to use them, how to use them, and how to manage side effects will be the focus of our evening discussion. I'm Dr. Hope Rugo, and I'll be moderating the meeting today on behalf of Dr. Neil Love, a great honor. And I am also honored to be joined by my colleagues we have a really incredible faculty here, the kind of faculty we can only get together at these really large international meetings. We have, just going from your left to right, Rebecca A Dent, Giuseppe Curigliano, and Nadia Harbeck, and then Erika Hamilton. I'm guessing all well known to you, so I won't take the time to go through all of their affiliations. So we have conflict of interest, and I'm going to flip through these quickly just to make sure that you can see the conflict of interest for all of the faculty. And Dr. Neil Love, who's the president of Research to Practice. So there is commercial support for today, and this is all outlined here. We're very grateful to our supporters for allowing these programs to proceed forward, so that's wonderful. And the Research to Practice and CME Planning Committee staff and reviewers who work at Research to Practice have no conflict of interest to disclose. So this program will contain discussion of non-approved uses of agents and regimens, ongoing trials, upcoming trials. Please refer to the official presenting information for each product for approved indications. So in order to make this meeting more relevant to participants, a survey of 50 general medical oncologists was conducted earlier this month. This is quite common with these programs, and I think it really gives us an idea of where the issues are. Questions and cases provided during that survey will be posed to the faculty throughout the meeting, so we'll hear what people think, and we'll also hear what the survey said. So this is where we're headed today. Professor Dent will begin by discussing the role of ADCs in metastatic triple-negative breast cancer. Professor Curigliano will discuss ADCs in HER2-positive metastatic disease. Then I'll cover the role of ADCs in endocrine-resistant HR-positive breast cancer. And then Professor Harbeck will discuss ADCs in localized disease. And we'll conclude with Dr. Hamilton's talk on the very important topic of managing toxicities from ADCs. So we're now going to go ahead with our first talk with Professor Dent, who I'm going to call by everybody's first name. So Rebecca Dent will start, and we'll go into this presentation and then our discussion afterwards. And don't forget, you can put your questions in online on the iPad as we go along.
Thanks so much, Hope. So really glad to be here with you. You know, normally triple negative goes last, but I think we think it's so important that it gets to go first now. So I think at this year's meeting, we've also seen a lot of data in triple negative, and you'll see more tomorrow. So I'm going to walk you through some of the most recent data, but I do like to sort of create a story. So I think it's really important first to talk about where we've been. And I think it's really exciting because 10 years ago, triple-negative breast cancer did not have its own guideline. It was sort of like, do whatever you're going to do with ER-positive, HER2-negative disease. Whereas now we have our own guideline, and NCCN has its guideline. And just days ago, we have the ESMO guideline, and we now have biomarkers, and we also have multiple choices. And as you can see here, the biggest unmet need really has been in this PD-L1 negative group, which represents about 70% of breast cancers. And now we have two ADCs that are now listed in all of the guidelines. So it's an exciting time to treat triple-negative breast cancer, I think anyway. So if you think about triple-negative breast cancer, it affects about 15% of all women. If you're a patient who is of Indian ethnicity, though, and you're premenopausal or you're from Africa, that's actually as high as 50%. So depending where you are in the world and your ethnicity, we actually have a number of patients who are triple-negative breast cancer. Now, we know that these are aggressive cancers, especially when they relapse. Up to 50% of them will have brain metastases, And now that we're treating with aggressive therapies in the curative setting, what we know is when they relapse, it's very aggressive. It's even harder to treat. And the majority of the relapsers now are actually early relapsing TNBC, which for those of us in clinical practice has made our job a lot harder. So I think this is the only study that I know of, so I'm putting it in there, looking at just early relapsing TNBC, and this was published a few years ago already, looking at the role of immunotherapy in patients that relapse, up to 12 months since their adjuvant therapy. And this was a negative study, but I highlight it because it tells us that these early relapsing triple negatives do very poorly, with a median PFS of 4 months and survival of 12 months. And remember, this includes PD-L1 positive patients who do better. So PD-L1 negative, their median PFS was actually 2.8 months, and OS was actually even shorter. So this is a very dire group of patients. Now, I wanted to touch briefly on how things have evolved in triple negative, because if you look at the two trials I'm going to talk about, the ASCENT-03 and TROPION-Breast02, what's really interesting is that in the control arm, both of those studies had over 50% use of taxanes, and then you see a myriad of other options for patients, and that's because in triple negative, we don't know what the best standard chemotherapy. So just like as we saw with the PARP inhibitor trials, we see a variety of different options because, again, there is no standard for triple negative breast cancer, but we see things like eribulin moving up early in the course of our treatment options. So I think we're all familiar with the fact that there's a tsunami of ADCs in clinical trials, but the top ones that you see there are the ones that we're able to use in clinical practice. So these are directed at TROP2 and directed at HER2. This story started a few years ago when data with sacituzumab govitecan, or SG, showed us that in patients who had 2 or prior lines of therapy, we saw finally a median improvement in PFS and an almost doubling of median overall survival. So this was the first ADC approved in metastatic triple-negative breast cancer. But the field is getting very busy. We have OptiTrop study with SAC-TMT, another TROP2-directed ADC, which very similarly showed improvements in PFS and OS. And I think many of you have seen this particular compound in many different tumor types showing activity that's quite pronounced. We've also seen data with TDXD and HER2 low. So we know that this is the DESTINY-Breast04 study looking ER positive, but there were about a small subset of those patients were actually triple negative. Now, it was a small number, but dramatic improvements in PFS and OS, and for this reason, the FDA approved this for triple-negative breast cancer. Now, I think because this was a smaller number, I think that many of us are not using as much TDXD, but it is still an option that we can consider in our triple-negative breast cancer patients. Now, one of the things I want to touch on is the 2 trials I'm going to mention in this particular presentation talk about PD-L1 inhibitor ineligible. And I wanted to explain what that means. So when we're in clinical practice, about 60 to 70% of patients will be PD-L1 negative, defined by CPS scores less than 10. But you'll have patients that are medically contraindicated. They can't get immunotherapy. It's unsuitable because it's less than 12 months since they've received their curative therapy. And then there'll be certain areas where they still can't access it. And then perhaps it's not available for testing, and maybe in the old sample it was negative. So this is just to remind us that we have about 70% of patients that are like this in our clinical practice. So at this year's ESMO, it was very exciting. Javier Cortez, my good friend, he presented the ASCENT-03 data, and I presented the TROPION-Breast02 data together. Both of these trials were first-line studies looking at TROP2-directed ADCs in our first-line triple-negative population. At last year's ASCO, we saw the ASCENT-04, which is looking at the PD-L1 positive patients, looking at sacituzumab in combination with pembro, and then we have the ongoing TROPION-Breast05 study. ASCENT-03, I think you're all sort of familiar with this now, but I want to highlight a couple of key things. This is for patients that were first-line triple-negative, a 6-month window, greater than 6 months since they had their adjuvant therapy. They were allowed on if they had treated stable CNS disease, were randomized to receive sacituzumab versus chemotherapy of physician's choice, which could be a taxane or gem-carbo. Primary endpoint was progression-free survival. And what we see here is an improvement in PFS from 6.9 to 9.7 months. You can see their numerical trend in terms of improvement in overall survival. But remember, patients were provided with crossover sacituzumab upon progression, which obviously will confound the overall survival data. And it was very early at the time of this readout. Looking at the responses, we see not a big difference between SG and chemotherapy, but what's really quite remarkable is the duration of response. So across all of the antibody-drug conjugates, what we see is that there's clearly an effect on the microenvironment. And what that means is that if you get a response, which you're after, that response will be sustained. And that is what is so unique about antibody-drug conjugates. And then you see a complete response rate of 5 versus 7% with SG. Looking at TROPION-Breast02, very similar study design to ASCENT-03. As you all know, Dato-DXd is a TROP2-directed antibody-drug conjugate. Big difference here, any DFI was allowed. So patients less than 12 months, even less than 6 months were allowed, de novo, and greater than 12 months. Patients were randomized to receive Dato-DXd, which is given every 3 weeks, versus physician's choice. So if they were early relapsing TNBC, they were allowed to get either eribulin, capecitabine, or carbo because they would have just received a taxane in the curative setting. If it was greater than 12 months or de novo, they could receive nab-paclitaxel or solvent-based. The majority of patients chose nab-paclitaxel. Primary endpoints were PFS and overall survival. Now, one point of interest that I think is really important and relevant for clinical practice is we're seeing a lot of early relapsers within that first 6 months. And in this trial, about 15% of patients were actually in that first 6 months since they had their adjuvant therapy. So a very high-risk group of patients. What you can see here is that very early drop. So remember, these are very aggressive patients with triple-negative breast cancer. So you see an immediate drop in terms of PFS, an improvement from 5.6 to 10.8, an improvement in the delta of 5 months. In terms of overall survival, we similarly saw a 5-month improvement in overall survival. And we see a 24-month median overall survival with Dato-DXd. So again, showing that we're finally making a difference in these young patients with triple-negative breast cancer. Similar to what we saw with the ASCENT study, again, this duration of response is considerably longer than we see with chemotherapy. 5-month improvement in duration of response. And I think what's most notable is we're seeing over 60% response rate with Dato-DXd versus 30% with chemo, and a more than tripling of the complete response, so 2.5 to 9% complete response in triple-negative breast cancer. Now, this translated, I think many of you might have heard, about 10 days ago, this was approved by the FDA, and so now we can prescribe Dato-DXd in early relapsing triple-negative and first-line triple-negative breast cancer. So this is really just to show us in this setting. So Keynote 355, we had about 20% of these patients that were early relapsing, and ASCENT-03, about 20%. And what we see in TROPION-Breast02 is that, again, about 20%, but 15% overall were less than 6 months. So finally, I just want to talk for a few minutes about ADCs and immune checkpoint inhibitors. You know, preclinically, we've rationalized that if we're giving ADCs, what we see is increased T-cell infiltration. This is potentially a way to make a cold tumor hot. And so combining ADCs with immune checkpoint inhibition is not just additive, it's potentially synergistic, really changing the whole microenvironment and landscape of the tumor. And so ASCENT-04, presented by Sarah Taleni last year, looked at patients that were PD-L1 positive, again defined by 22C3 assay, looking at giving chemo plus pembro versus giving sacituzumab plus pembrolizumab. Primary endpoint, PFS by BICR. And what you can see here is an improvement from 7.8 to 11.2 months. And this benefit was seen across all these different pre-specified subgroups. And then tomorrow at the meeting, you'll see PFS2 data, again, showing how important this PFS2. So you're going to see actually data tomorrow, all 3 of these trials, so the 2 first-line trials, as well as this trial, all showing, I think you've seen probably the data online, showing how impressive the PFS2 data is. And this makes sense, to be honest, whether or not you give the immunotherapy, but I think is most pronounced when you're combining it with immune checkpoint inhibition. And again, this is just confirming this long duration of response that you're seeing, especially when you're combining the immunotherapy with ADC. Now, it's not just the sacituzumab and the pembrolizumab. We're also seeing the same thing with Dato-DXd and Durva. This is, data that we saw from Begonia that was published actually also a couple of weeks ago. And I think those forest plots, we could rival our lung cancer doctors. We're seeing very deep, prolonged responses when we combine an ADC with immune checkpoint inhibition. I will highlight, though, that 90% of these tumors were actually PD-L1 negative. So I'm most excited for the future looking at PD-L1 negative tumors. Can we convert them to be hot? And so there are a number of trials looking at these strategies. You'll notice the ones in the bottom are looking at sac-TMT in combination with pembrolizumab, and then you're looking there at Dato-Durva. And again, these are in PD-L1 negative patients. And finally, this is work that Erika Hamilton was involved in. So I think it's so important in triple negative to look at the tumor microenvironment. How we're really going to change the natural history of TNBC is to change that tumor microenvironment. So this is a bispecific agent targeting VEGF-A and PD-L1. Again, targeting the microenvironment. In this study, they looked in first-line setting. The majority of these patients or 50% of them had chemo in the early breast cancer setting. Quite an impressive waterfall plot. Almost all patients had some kind of tumor shrinkage, 97% disease control rate. So I think for me, this sort of highlights, this is proof of concept that when you combine an ADC with something that's targeting the microenvironment, you see quite impressive results, and that they're looking at the Rosetta Breast 01 trial is looking at incorporating ADCs as well as chemo in combination with PUMI. And so finally, I think anybody who treats triple negative, this is where we struggle. 50% of our patients will develop CNS mets. We might have control of other disease, but people actually die of their CNS mets and have terrible morbidities associated with it. We saw some data with sacituzumab in the ASCENT trial that showed modest improvements in PFS. We didn't see a lot in terms of overall survival, but we're hoping to see in the future, does SASI have activity in the brain? Our colleague, Rupert Barch, has actually done some really interesting work with the Tuxedo set of trials. These are investigator-initiated trials, and these are actually patients who have progressive disease in the CNS, and they looked at giving Dato on its own. And this is really just a highlight. Clearly has some response in the brain. This is a compound that's similar to TDXD. I think we have every reason to think that this might actually be active in the CNS. So we now clearly, hopefully I've shown you, in that first-line setting, especially in triple negative, we have benefits in terms of PFS and OS with not just immunotherapy, but with ADCs, and certainly in the combination, it's augmented. Now we just have to look at how we sequence it. Erika is going to tell us how we manage the side effects, and I think in the future, the lack of targets will no longer define this aggressive disease. Thanks.
Thanks very much. Great. So we're going to move on to some of the discussions. So very interesting time where we have a number of different drugs in the same setting to try and figure out what to do and how to manage the sequencing of treatment. So we'll first talk about this patient, a 68-year-old woman with TNBC, 18 years ago treated with local therapy and chemotherapy. She has an axillary mass now and has TNBC, HER2 2+, PD-L1 negative, and a PET scan shows metastatic disease to bone and nodes. I have to say, I don't think I've ever seen a patient with metastatic disease 18 years after initial cancer, but these things do occur, and maybe it was a new cancer somewhere. So how would you choose? I think the biggest issue for us now is how do you choose between SG and Dato-DXd? What factors do you think about? And, then we'll talk about the side effect profiles in just a moment. So, Nadia, how would you think about choosing one drug versus another?
Well, I think here we need to look at the side effect profile, and we need to look at the way these drugs are administered. The Saxi patients have to come in week 1, week 8, and Dato is only every 3 weeks, and all of these factors help to shape the decision. Actually, I think both trials, like Rebecca showed, are terrific. I think the data are great. The quality of life is good in these patients. So I think you can use either one.
And when we're thinking about the side effect profiles, that sometimes lets us think about whether we're going to give one drug versus another. I guess the next question really is balancing these toxicities and how that impacts your treatment selection. Erika, how do you think about that?
Yeah, absolutely. I think with sacituzumab, we think more about diarrhea as a side effect and count disturbance. We typically use growth factor prophylactically after that day 8 administration with sacituzumab. With Dato-DXd, we can see some eye toxicity. This doesn't tend to be more severe eye toxicity like a mirvetuximab eye toxicity, but we do need to watch out for dry eyes and do kind of a baseline eye exam on Dato-DXd. And sometimes kind of follow those eye toxicity. But what I really watch out for with Dato-DXd is stomatitis. I think it's really important to use a prophylactic steroid mouth rinse. The only patients that I've really had that have gotten into trouble with stomatitis are the ones that have stopped their prophylactic steroid mouth rinse. If they do get mouth sores, sometimes that can be tough to get rid of.
So I've seen the same thing.
Yeah, so I really kind of caution my patients, even if you're 2 weeks in and you don't have mouth sores, don't think, oh, I'm just a patient that's not going to have it and stop. You really need to keep going with that steroid mouth rinse.
No, it's a really good point. And then, we know DXD has got the same payload. A lot of resistance is related to the payload. So if you had a patient treated with Dato, would you give TDXD? If you had a TROP2 up front, do you think it matters to sandwich with chemo, Giuseppe?
No, this is an excellent question, of course. So giving datopotamab deruxtecan as first line, I would give a sandwich before giving again trastuzumab deruxtecan because the payload is very similar. There is a different target antigen, but I will feel more comfortable to give a chemotherapy like eribulin after datopotamab deruxtecan. Then I will check the median time to progression. And in case of new progression, of course, I will go for trastuzumab deruxtecan. This is a special case. You selected a really special case because in my country, having a 68-year-old woman you need someone of the family that will bring the patient in the hospital. And so, in my opinion, in a patient like this, datopotamab can be a best option. It's every 3 weeks. You don't need to manage neutropenia and diarrhea, so the only thing is to educate the patient to the swish in order to prevent the mucositis, the stomatitis. And at the end of the story, you have a median PFS and overall survival benefit. And so we have at least 2 reasons to do it Dato or now or never, front line. And at the end of the story, in an elderly patient, without comorbidities, I suppose here, I believe you are offering a treatment in which the access to the hospital is not after 8 days. This can be an issue sometimes.
Certainly it can, and it depends on the patient age, obviously, and what they're doing. But Rebecca, would you agree that that's how you would decide about using your first-line treatment? And then would you give Dato after SG, the converse? Or do you choose TDXD?
So I agree this scenario is not so common in my practice. And I think Sarah...
You can say it's 3 years.
Well, no, but I think what's really interesting is that Sarah's looked at this and shown that we're seeing a lot more early relapsing TNBC and she's seeing a lot more late TNBC. So I think the first thing is when patients have just had the Keynote 522 regimen, their marrow is very tired. And so the unique part of Dato is that it isn't myelosuppressive. And so the every 3-week dosing is very attractive to patients. Their marrow isn't suppressed, and in a country where you have to do it exactly as the trial did it, if it's 3 months out, you can give Dato where you wouldn't be able to give Sazi. Now, in a patient that's greater than a year out, I think it would vary. What like Erika said, it depends on the side effect profile. A lot of clinicians are used to using Sazi. In a patient who has very aggressive disease, I think the responses that we're getting with Dato they're the deepest we've seen. A 10% complete response rate is just something you just don't see that often. But I think it's exciting. Both drugs seem to really work well in that first-line setting. I'm most excited to look at the CNS disease because I'm plagued by really bad CNS disease. So I'm hoping that will shed some light and give us some further help with that. How to sequence? We need newer ADCs with better payloads. I'm really excited about the combination with these bispecifics. I think that's where I'm seeing all of us have in our practice patients that have these very prolonged responses that are almost cured. I think we'll get more of those when we do this approach.
Great. Thanks. And there was a question, and I think we can answer it along with this, which was, from the audience, any role for Pembro ADC combo in low PD-L1. So not 0, but less than 10. So we can talk about it here, but this is a 47-year-old woman who has de novo stage 4 TNBC, just terrible cases we see in practice, bone and liver mets. She has a germline BRCA mutation and a PD-L1 CPS of 10. So now we have 2 possible treatments, both of which have very good efficacy. How would you manage the case? Would you start with a PARP inhibitor or IO-based approach? And would you combine with pembrolizumab, and which PARP inhibitor do you use? So, Erika.
Yeah, I mean, I think, our TROP2 ADC here would be sacituzumab govitecan in combination with pembrolizumab, but, we also have the BRCA alteration. In this case where we have kind of 2 choices, I'd really be favoring the TROP2 ADC with pembrolizumab. We have evidence for overall survival here. The PARP inhibitors, we really don't have evidence for overall survival. So I'd be favoring using the immunotherapy first and then thinking about using the PARP inhibitor second in this case if I was picking with sequencing.
Which PARP inhibitor do you go?
I really don't have a strong preference. I think that there are subtle side effect differences, but have used both.
Yeah. I think a lot of people use olaparib. And so we'll go on to the next case, but Nadia, do you think there's any role for giving Pembro with an ADC and PD-L1 low?
I mean, in Europe, we also have Atezo approved, so we answer that question by just giving Atezo if there's an immune cell score of 1, and it works, So, but I think the data shows that the higher the immunogenicity, the better Pembro works. So I think we have other options now. Rebecca discussed them, so I probably would not give an IO.
And so we now have a 62-year-old woman with de novo TNBC again, liver and bone mets, CPS of 10, HER2 0, type 2 diabetes, moderate baseline peripheral neuropathy. She had gotten in first line carbopaclitaxel and pembrolizumab and had a response, but that only lasted for 11 months. So now what are you going to offer this patient, keeping in mind she does have these underlying comorbidities? Rebecca?
So yes, I think this is a common scenario that happens in practice. So I think there is a bit of a data-free zone in a way, right? Because we had about 5% of patients on the Dato-DXd study that had prior IO, but there's no way you can make any definitive conclusions what to do with that. One of the things that I've been finding is that, so we haven't been able to do that, so we've been giving, we haven't been able to re-challenge with immunotherapy. So what we've been doing is giving the patients an ADC, and then what I'm finding is that their CPS score is actually very high after I've given an ADC, which I think really shows us that we are seeing this conversion to an immunogenic tumor. So I think that space, will evolve. But I think we really don't know whether we should or not in that scenario. I think it's very reasonable to re-challenge, but I think I would give an ADC if you were.
I think that, we're going to go on to the next talk, but I will just ask you, Giuseppe, without the case really so much, is SAC-TMT very different from SG and Dato? Do you think this is going to be markedly different or similar?
No, there is, of course, a safety profile that is a little bit different for sacituzumab tirumotecan. So personally, I have only experience in the context of clinical trial with this agent, mainly in the post-neoadjuvant high risk after residual disease. In my experience, tolerability is very good. I did not observe mucositis or diarrhea in my patients. In terms of hematological toxicity, is very similar to datopotamab. Overall, I believe is well tolerated. Of course, testing it in a post-neoadjuvant setting is a different completely scenario. I never use it in the metastatic setting because the data presented a few years ago were from a Chinese study. But I know there is a study ongoing also in the metastatic
setting. We have
yes.
Trophus 11 ongoing in first-line metastatic TNBC.
Correct, yes.
So let's go into the treatment of HER2-positive metastatic breast cancer with Giuseppe. We'll start talking. Thank you.
Okay. In the next 20 minutes, 10 minutes, I will try to provide an overview of what is going on in HER2-positive disease. What we did until a few months ago was the Cleopatra regimen, so a combination of pertuzumab, trastuzumab, and taxane, with a clear improvement of median progression-free survival up to 19 months and an overall survival benefit, because if we see the long-term follow-up of the Cleopatra, we have patients that potentially are cured with metastatic disease. So you would agree with me that that plateau is really a representation of some patients that potentially have been cured. So what is going on actually after the Cleopatra? We had the Patina trial. So you do an induction with the Cleopatra regimen, and then you maintain with palbociclib, pertuzumab, trastuzumab, and endocrine therapy. Here, we had an impressive improvement in median progression-free survival up to 44 months, but post-Cleopatra setting. This is not after trastuzumab deruxtecan. And so what is demonstrating the Patina trial? First, that if we add a CDK4/6 inhibitor like palbo to the actual maintenance with dual blockade and endocrine therapy in HR-positive, you can improve median progression-free survival up to 15 months. All patients received endocrine therapy, only applies to HR-positive or HER2-positive, and of course requires lack of progression during induction therapy. So all the patients in the Patina trial were responsive to the Cleopatra regimen. The second study is their 2CLIMB-05. Tomorrow, Professor Hamilton will present an update of the study. Here we have exactly the same design. Cleopatra regimen as an induction. You stop and you maintain, in this case, with trastuzumab, pertuzumab, and tucatinib. Was also permitted endocrine therapy, but very few patients receiving endocrine therapy eventually. Here we have clearly another benefit in median progression-free survival. So addition of tucatinib to maintenance HP significantly improved the median progression-free survival by 9 months. Larger benefits has been seen in HR-negative disease. The absolute PFS is lower than would have anticipated, particularly with almost 70% of the patients having de novo disease. There is also, after induction, a probability of having a complete response during the maintenance setting, but still overall survival and PFS too are immature. So now we have the ADC in the first line, and we have the DESTINY-9. Prospective randomized trial, 3 arms, TDX alone, we don't have the data, TDXD and pertuzumab and Cleopatra regimen. Dramatic improvement in median PFS up to 40 months versus 26.9 months in the Cleopatra. So there is an outperformance of the Cleopatra. In the original trial was 19 months. So across subgroup, we have exactly the same benefit. This is a new standard of care. We incorporated in the ESMO guidelines. The advice is to use trastuzumab deruxtecan and pertuzumab in the first-line setting. If we check, of course, in terms of clinical benefit, we have a confirmed overall response rate of 85%, and also PFS2 investigator assessed is very good. Of course, this is a new standard of care. 44 months are unprecedented data. This is the longest PFS that have been achieved in HER2-positive disease. We need to understand overall survival is immature, but of course we are complaining eventually how much cycles we should receive. You saw some subgroup analysis that has been presented yesterday in the DESTINY-9, in which median PFS has been evaluated according to type of response, complete response, deep PR with a reduction of diameter more than 80% and partial response. And it seems that more better is the response, longer is the median progression-free survival. So what about patients that weren't included in DESTINY-9? We have this beautiful study, a phase 2 open-label single-arm international multi-center study in which there is a proactive toxicity management using digital tools. And then we have another study, actually, that is a maintenance study, because what we do in the Cleopatra is actually to stop and to maintain, but we cannot extrapolate our 2CLIMB-05 and Patina after trastuzumab deruxtecan and pertuzumab. That's why we have one study that is the Demeter. I don't know if this is the ideal study, because you are going to deliver 6 administration of trastuzumab deruxtecan. Whatever it is the response, you stop and you maintain with dual blockade plus endocrine therapy. we know perfectly that sometimes you need a longer exposure to trastuzumab deruxtecan to achieve a better response. And this can be a limitation of the Demeter trial. That's why there is another study that is the Destiny Breast Guide. So patients HER2-positive disease that received trastuzumab deruxtecan and pertuzumab in the first line. And so they will receive a median of 18-24 cycle if they will not achieve a complete response. For those who will achieve a complete response, they will stop after 8 cycles, and they will maintain with the patina regimen. So this is only for HR-positive disease. So HER2-positive, HR-positive. I believe this is an interesting study. It's going to evaluate after induction the role of the patina regimen following trastuzumab deruxtecan and pertuzumab. And in case of progression, you can re-challenge again with trastuzumab deruxtecan. Very pragmatic study that will answer our questions. So, at the end of the story, maintenance is still an open question. You agree with me? Because, 44 months of control of the disease. I know we have some patients that have an excellent tolerability to trastuzumab deruxtecan, but we have also to understand that maybe some patients cannot tolerate. You need to stop and to maintain. And I believe studies like these are really very important in order to understand what is going on. Another study ongoing for HR-positive, HER2-positive is the HERDERA with giredestrant plus dual blockade, and the other one is INAVO 120 for HER2-positive PI3 kinase mutant. This is the design of INAVO 122, so induction with the Cleopatra, PI3 kinase mutant selected, and then you randomize to pertuzumab, trastuzumab, endocrine therapy, placebo versus pertuzumab, trastuzumab, and inavolisib. Also in this study, investigators forget usually to combine the endocrine therapy. So we retrain it again several times, the investigator. And this is the HERDERA, so giredestrant plus pertuzumab, trastuzumab versus pertuzumab, trastuzumab as standard of care. Very two interesting study. So is there an optimal duration for induction? This is unknown. We know that sometimes you need really a longer exposure to achieve an optimal response. Of course, T-DXd and pertuzumab duration sometimes is not limited by dose-dependent toxicity, but sometimes you may have potential activity. And then does induction duration need to be individualized? So I mean, do we need biomarkers eventually to select these patients? What to do in brain mets? We have clear evidence from the analysis of Destiny 1, 2, and 3 that you can achieve impressive response rate with trastuzumab deruxtecan. These are the data in the pooled analysis of Destiny 1, 2, and 3, and then we have the Tuxedo study, frontline, and of course the DEBRA, and the Destiny 12, in which is very clear that TDX for patients with baseline brain mets is the new standard of care. And we have to consider absolutely this because we have an overall response rate of 82% in patients with untreated. So you can delay radiation therapy. You can start directly with TDX if you have asymptomatic brain mets. And the baseline brain mets CNS PFS at 1 year is 58.9%. That is a huge achievement in this population. These are the data on overall survival. What is going on in terms of other agents? This is a new ADC, Horizon 01, demonstrated in the context of a prospective randomized trial, a potential activity. The control arm is not trastuzumab deruxtecan, but it's a very interesting ADC because it's very similar to trastuzumab deruxtecan and conjugated with a topo-1 inhibitor. These are the data in terms of median progression-free survival. Remember that the control arm is not trastuzumab deruxtecan. Also, the data of overall survival are impressive. So in conclusion, I believe we need to better understand the optimal duration of T-DXd plus pertuzumab. The open question is whether maintenance approach should be personalized based to a biomarker outside or just ER status, so MRD or eventually R2DX. Are maintenance strategies really the way to go, or we should continue until progression? And finally, while we have made a tremendous improvement in outcome, we need really still to optimize treatment. Thank you.
Right. That was excellent, and I think so interesting to hear about all the things that are being considered to try and move on from the amazing advances we've made in HER2-positive disease. It's kind of astonishing when you think back to 2000 and whenever it was, 3, where we were all in Orlando watching as if it was, being on the cover of the Rolling Stones. It was like, massive room full and overflow rooms and standing ovation. I mean, trastuzumab changing the world for women with HER2-positive breast cancer. And now, we've, in the adjuvant setting, now we've really made this huge advance. So let's talk about some of the questions that we have. A 42-year-old woman who has de novo HER2-positive, HR-positive breast cancer with brain mets. So we do see these patients present with brain metastases. And a lot of women now are getting brain MRIs, right, when they present. And so we find them even when people are asymptomatic. So she's treated with SRS and then is started on TDXD and pertuzumab a la DB09. So the questions really are, would you start with DB09 type treatment in all patients? Is this the current standard of care for everyone, or is there an alternative? Do you use Cleopatra in some settings? And when would you even consider endocrine therapy and HER2 targeted therapy? And then, of course, the maintenance question: do you continue forever? And she had brain mets, and what would you do? And if you stopped, what would you change to? So let's start with Nadia.
Well, I think it's a great regimen. We don't use it in everybody. We use it in patients where we have a need for fast remission. But in like an elderly lady with just 1 or 2 oligometastatic disease or so, I would probably still give Cleopatra regimen. And we're running the top real study that Giuseppe showed in our country. So we have the choice of stopping TDXD plus P after we think we've reached a good remission, and then go with the endocrine-based patina regimen or with the tucatinib regimen in the HR-negative disease as a maintenance. And the interesting thing that we're evaluating in these ongoing trials is also, can we re-challenge with TDXD plus P? Because that's what we do. If we do a drug holiday and stop not for progression, then we could re-challenge. You cannot do this in all countries, but I think in the US you have no problems, and also we in Germany don't. So I would probably probably not after 6 cycles fixed like in the Demeter trial, but maybe after a year or so we stop and go for maintenance therapy depending on toxicity as well.
Yeah, I think that's a very appealing approach, and we'll keep talking about these patients here. We have a 63-year-old woman who has de novo HER2-positive disease. Now it's HR-negative. She has liver, bone, and brain metastases with 3 small asymptomatic brain lesions. So she is treated with DB09 approach with TDXD and pertuzumab. She has a partial response at 3 months with stable CNS disease. But at cycle 8, she's found to have symptomatic grade 2 ILD. So her TDXD is held and she started steroids. Now, in general, we not supposed to re-challenge with TDXD after grade 2 ILD. It does resolve on imaging, and her symptoms resolve after 6 weeks. So now she has enlarging brain lesions, but nothing else systemically. So, it's a big question. What are you going to give this patient who's received TDXD and pertuzumab after her initial treatment? Now, a separate question is, can TDXD be reinitiated after ILD resolution? Because in this case, it's really not recommended at all because of the symptomatic disease. So, Erika, what would you do here?
Yeah, I think she has a new brain lesion. We know that trastuzumab deruxtecan actually has fantastic brain activity. So, this is a pretty worrisome case, the fact that, only after 8 cycles she's progressing in the brain. So I would be thinking about Kate-Traz tucatinib. It's probably the agent that we have the strongest CNS data. So I'd be thinking about that for her, and certainly, thinking about treating that brain lesion that's progressing with SRS.
And would there ever be a situation where you would start the treatment and wait on the SRS in this kind of setting where she's already been treated with SRS, has progression?
Yeah, I mean, we certainly did have the ability to do that on trial. I did do that for select patients. It really depends on the size of the brain lesion, whether that brain lesion is symptomatic versus asymptomatic. So certainly, yes, I did treat several patients without locally treating their brain disease and actually saw great responses.
And do you ever give TDXD after symptomatic ILD?
Oh, you're going to make me commit to this. I have. You're not supposed to?
No.
I know.
It's on the label.
I know, but I have. I don't think all grade 2 ILDs are created equal. I think, if you have decreased oxygenation, et cetera, I don't feel comfortable re-challenging that. Grade 3 is hospitalization. Grade 2, that's a pretty big bucket, and there's a lot of things that go into grade 2. Something that has a little bit of a cough, but otherwise had an O2 stat of 100%, et cetera, and was kind of a soft call.
A recent viral infection.
Right. I might be willing to re-challenge that one, but somebody that had some really objective symptoms, I'm not going to re-challenge that. I think you have to have a really transparent conversation with that patient, and they have to really understand what they're signing up for.
Absolutely. Now this patient, if the patient was a little bit different and you gave, either THP or TDXD pertuzumab, and this patient has HR negative, HER2 positive disease, when would you use tucatinib as part of the maintenance therapy as a la HER2 Climb 05? Giuseppe?
If this patient had a grade 2 ILD, I will not re-challenge personally.
So this is the question here is a little bit different. So the patient has gotten an induction chemo, either with TDXTP or with THP. She's had a great response, and she says, look, I just need to break from chemotherapy. What can I do instead? When are you using tucatinib as part of maintenance therapy?
This is a scenario where I would use tucatinib as a maintenance therapy, of course. It's HR negative, and finally she had a response. She's tired to continue with the TDX or Cleopatra. And this is a typical scenario where I would consider eventually pertuzumab, trastuzumab, and tucatinib as a maintenance therapy. Because according to the data that we have, these are patients that can benefit potentially of this. So personally, in this patient, this would be my proposal as maintenance.
So these patients do get diarrhea from the tucatinib, and it's not part of our ADC talk, but it's part of what we're doing as maintenance. Do you dose reduce when you give the tucatinib?
No, I can do two things. I can dose reduce, but eventually I can also remove pertuzumab, giving trastuzumab and tucatinib,
So there's a lot of ways.
There are several options eventually, yes.
A lot of ways to manage things. You really have to individualize this with the patient. So now we have a 62-year-old woman who has stage 3C HER2-positive breast cancer, gets neoadjuvant TCHP, has a PCR, and then gets adjuvant HP to complete a year, but 6 months afterwards, a horrible situation where she presents with a 2-centimeter symptomatic frontal lobe brain lesion and has craniotomy, which I think is actually quite commonly done for these single lesions that you can remove. And her PET scan doesn't show any other disease sites, and generally we would do radiation post-surgery, I think, for most of these patients. So what's the role? Actually, we just talked about a case like this I think on Saturday at one of our sessions. What's the role of TDXD or other therapies in this setting of NED? How frequently do you conduct brain MRIs for this patient? And do you do ctDNA ever to try and understand how much disease the patient has? Rebecca?
So I would agree with you. This is something that happens quite commonly, and since we are at the ASCO meeting, I think it's worth commenting that it's not mine. That the initial guidelines, the way they're written, suggested if you have isolated CNS metastases and it's fully resected, there wouldn't be any role to sort of change systemic therapy. Yes. Having said that, the guideline was before we had agents that clearly were active in the CNS. So, I think I take these situations case by case. In this particular case, there's one lesion. It's been completely resected. I think it's reasonable to say follow every 3 months with imaging. And I think data will tell us whether ctDNA contributes to that. But for now, I probably wouldn't. If I had somebody who had more aggressive CNS disease and I was concerned that it wasn't all resected or there were other factors, I might consider it. But for now, I would follow the ASCO guidelines and just watch very closely. Because I have numerous patients like this who are, doing very well with no recurrence. And if you're going to treat, how long do you treat? What are you monitoring? You don't
That was my next question. So if you did, let's say you said you'd consider...
I haven't. I'll be honest, I haven't. But I have done second opinions on patients, and usually I'm doing the second opinion because how long should we treat? And, they don't know how long to treat because they don't know what they're following. So I think for now, for the most part, in this kind of scenario, I watch very closely with every 3-month MRIs. And, there's a lot of good new CTG technologies that hopefully if we evaluate them, maybe they can help guide us a little better. But I would do every 3-month MRI testing for now.
And if a patient has, say, 5 lesions treated with SRS and didn't have surgery,
yes,
and looks fine,
it's another patient.
Okay, Ness, we're going to give TDXT. How long are we going to give it for? Everything's stable in 6 months. You've given 8 cycles of TDXT. Patient says, boy, I really want to go on my month-long trip that I planned 2 years ago.
Well, they can still go on that month-long trip.
And I'm
tired.
I'm tired. I need a break.
So we don't know, right? So again, you'd individualize it. I think giving them at least 6 to 9 months is probably, for me, important. And then I would watch them closely. I think the bigger question is, do you do anything else after that, right?
Would you give them tucatinib HP after that when they go on to maintenance?
Again, that's going to be a lot of side effects, right?
Yeah.
So I think the heavier the burden, you'd be a lot more tempted to, quite honestly, and you'd individualize it. But if you gave sort of Herceptin and tucatinib without any chemo or anything else, that's a little bit better tolerated, to be honest. So it would depend how aggressive the CNS disease, and if you're really convinced that they're NED in the brain. But if you've got 5 or 6 lesions, sorry, that's bad disease. I would like to continue something.
So the HER2 TKD mutations was one question, tyrosine kinase domain mutations, and these are, interesting. And would you use a tyrosine kinase inhibitor as ongertinib? It's not approved, and so we don't have it. And we do see somatic mutations in HER2, more in lobular than other cancers. So just a quick question. If somebody has a HER2 mutation, do you give TDXT?
Yes, there is a study, finally, that has been done in HER2 mutant disease, and it works, finally. HER2 mutations are more common in HR-positive, HER2-positive. You never find in HR-negative. So, since HR-positive, HER2-positive are very close to HER2 low, trastuzumab deruxtecan may work. This is an highly selective TKI. I believe you saw the data in lung cancer. There will be some data also in breast cancer presented in San Antonio on this. Very interesting.
So I think that'll be great. It's a small number of patients, but we find them now because we do NGS on everybody. And so I think it is an argument to do it because you might have additional treatment options for patients. So we've had a really interesting conversation. We didn't really answer the question about whether we would give TDXTMP for everybody, but I think for most was the idea with a maintenance approach, and maybe in an older patient or a patient where you wanted to, maybe low burden of disease, I think is what you said, Nadia, that you would give THP, and I think probably the panel would generally agree. So let's go on and talk about ADCs and endocrine-resistant, HR-positive, HER2-negative advanced disease. There are 3 ADCs approved for this treatment: trastuzumab deruxtecan, datopotamab deruxtecan, and sacituzumab govitecan. TDXT is approved in the United States in the first or greater line setting. Dato and SG are approved after at least 1 line of chemotherapy, and all require treatment with prior endocrine therapy with some development of, evidence of endocrine resistance. So let's talk about the specific data that we have. So TROPiCS-02 was the first trial to look at an ADC in patients with endocrine-resistant, HR-positive, HER2-negative disease. And so, the first trials tend to treat the most resistant and heavily pretreated patients. These patients had a median of 3 lines of prior chemotherapy for metastatic disease. They had received CDK4/6 inhibitors, a large number of them, and 95% have visceral Mets, which I have to say at the time was kind of a surprise. Now we're seeing it more and more, but almost everybody, 85% liver Mets. And that's what we're seeing now in this heavily, endocrine-intensive treatment with targeted therapies after lines of chemotherapy. And of course, patients could receive TPC, and the chemotherapy are listed there. I think they're quite reasonable: CAPE, Venerabine, and then you could take eribulin or gemcitabine. Or SG, which, as you know, is given day 1 and day 8, with a primary endpoint of PFS by blinded independent central review, because these trials can't be blinded to us, so we have to use BICR for evaluation of endpoint of PFS. We saw a significant improvement in progression-free and overall survival with a big initial drop-off, which was kind of interesting. So, you see that drop-off because these patients were so heavily pretreated. Some just had a lot of disease resistant to any chemotherapy approach. So even though the actual median was only 1.5 months, the hazard ratio is very good at 0.66, over meeting the objectives. And there was a big difference there at 12 months in terms of the patients who were progression-free, 7.1 versus 21%. So this, I think, is a really important treatment in that heavily pretreated setting. But times have changed since then, as we'll talk about it. We also saw an improvement in overall survival, as you can see. And again, when you look at the 12, 18, and 24 months, you're seeing a meaningful difference in overall survival with these patients. We found that there was no difference in response based on TROP2 expression level, and there's been lots of discussions about that, including some presentations here at this meeting. There's a suggestion maybe of some difference, but it's not enough to really make us change the way we do now, which is treat everybody. And of course, as you would expect, there was no difference based on HER2 IHC status. We saw increased responses in this later line setting and a longer median duration of response, as you can see. And we already knew what the toxicities of SG were, including neutropenia and diarrhea as the most common toxicities. And these are shown here, but they were very similar to what we saw in the heavily pretreated triple-negative breast cancer population. We'll talk more about a bit later about how to manage these toxicities. Then we saw a second study looking at a TROP2 ADC, datopotamab deruxtecan. In this trial, it was the next trial, so you could treat a less heavily pretreated population. So these were patients who had endocrine resistance or endocrine therapy was not suitable, previously treated with 1 to 2 lines of prior chemo, and the median for the group of patients was 1 line of prior chemotherapy, because then we already knew we wanted to give ADCs. Patients were randomized to Dato-DXd or treatment of physician choice, very similar chemotherapy regimens. And in both of these trials, more than half of the patients received eribulin as their chemotherapy of choice, which all makes sense to us because you're pretty far out and you don't have a lot of treatment options. There were dual primary endpoints of PFS by BICR and overall survival. And you can see the median follow-up is now 23 months in this patient population. 82% received prior CDK4/6 inhibitors. So you can see that progression-free survival was significantly improved in patients receiving Dato-DXd versus treatment of physician choice with good chemotherapy regimens. And if you look at the data at 12 months, it's quite similar to what we saw in the more heavily pretreated population who received SG with HR-positive disease, suggesting that these TROP2 ADCs all are effective in this setting, but we're seeing about the same differential. The hazard ratio is almost identical at 0.64, which is intriguing. In addition, you can see there was a huge separation for time to subsequent therapy, and this was true regardless of the prior duration of prior CDK4/6 inhibitors. So, you saw the benefit even in a more endocrine-sensitive population. So then we looked at overall survival, and we were kind of surprised. We saw OS and SG, and we didn't see it here. But of course, what was different when we looked at TB01 is that we had ADCs available, right? So patients could go on and get other ADCs. So the OS was then adjusted for subsequent ADC treatment with a post hoc sensitivity analysis. This data was just published earlier this year. And the hazard ratio is better at 0.86 with a confidence interval that barely goes over 1. So it shows you the impact of subsequent treatment here. And of course, we've seen that in the Destiny trial as well, which I'll show you in just a moment. Now, we'll talk more about toxicities in just a moment. You can see that everything moved around going from a MAC to a PC. But the most common toxicities for Dato you heard about earlier, and it's just a little bit different than what we saw with another trastuzumab deruxtecan or deruxtecan ADC. And what you can see is ILD is very low rate. So this is, I think, excellent. When you have the DAR is 4, that may have something to do with it, but probably a lot of it is also targeting TROP2 rather than HER2 and where these antigens are expressed. And then you see stomatitis. You can see that there's a lower rate of grade 3 stomatitis, and it's listed at the bottom of this slide. But grade 2 stomatitis is also bothersome for patients, and that was in 24% of patients. So the FDA label recommended cold chips, where we have absolutely no data that it helps mucositis, and these are long half-life drugs, so it didn't really make sense to me. But steroid mouthwash clearly works, and we're doing a current trial looking at steroid mouthwash in the SWISH trial in lung and breast cancer patients, and we'll talk more about management in a bit. Deruxtecan is a drug that causes nausea. It's a little lower than what we see with TDXT. Probably we need to be just using aggressive anti-nausea medications, and I think we've all found that to be very effective. We don't see the bone marrow suppression that we've seen with SG, which I think is intriguing. Now, we just saw the data of Ascento 7 looking at SG versus treatment of physician choice in the first-line setting, very similar to what we saw before, and you can see that about 43% of patients received capecitabine and 57% taxane as their treatment of physician choice. Again, these patients had a lot of visceral disease, almost 90%, almost 70% liver mets. We didn't see any difference in progression-free survival by blinded independent central review, which was interesting. But when we looked back, there was a lot of censoring. And then there were patients who actually had progressed with, increased new pleural effusions or new lesions in the liver, but Bicker said it wasn't certain. And so when we looked at PFS by investigator, we saw a 2-month difference in progression-free survival. That just wasn't the primary endpoint. So this trial was a negative trial, but I think the PFS is quite interesting. And then we did see a separation of overall survival that's also intriguing, only 27% maturity. So we're waiting and following up on this and hope for additional data later this year. And we'll see what happens at that time. But even if you think about the PFS in the patients who had, the investigator assessment, it's still shorter than what we saw in DB06, which I'll show you in just a moment. So it does bring up the question of the HER2 ADC. They're all topo-1 inhibitor payloads versus a TROP2 ADC. So there is actually an ongoing trial, TroFuse-10, looking at sacituzumab trumatecan, sac-TMT, and HR-positive endocrine-resistant disease. And the unique aspect of this trial, which is a 3:3:2 randomization, is that the middle arm includes pembrolizumab. And these patients have PD-L1 negative disease. So it will be quite intriguing to see the results of this trial. So Destiny Breast 04, of course, led to a standing ovation, and I think the next standing ovation we saw was yesterday. So with pancreatic cancer, amazing data. But this was, post-pandemic with incredible data showing the efficacy of TDXT in patients with hormone receptor-positive disease with these huge separation in PFS and OS that occurred right at the first presentation of data. And the TPC you can see here is very similar to what we saw in all of the prior trials, and it was a 2-to-1 randomization, remarkable improvement in overall response as well. So this really became a standard in this HER2-low population. As you know, there was a small number of patients, 58, with triple-negative HER2-low disease, and those patients also had a benefit, so the approval was broadly for HER2-low disease regardless of ER status. And I will point out that in this trial, HER2-low was determined centrally, standard 1+ or 2+ without gene amplification, not by the local sites. But the concordance wasn't terrible in previous data that was reported between the local sites and central sites, but it's brought up a storm of studies trying to figure out how to better assess HER2-low. And we'll see what happens with that in the future. So actually, DB06 was important for many reasons, but Giuseppe presented that data as a late-breaking abstract, the first time that ASCO had accepted an abstract and presented at 7 in the morning. Thankfully, we didn't have one this year as a break, because we also saw DB09 that way, in order to try and get this data out as quickly as possible. In this setting, patients who had endocrine-resistant disease, hormone receptor-positive, and HER2-low or ultra-low, so 10% or less partial membrane staining, determined centrally again, were randomized to TDXT and TPC. Here it was capecitabine, NAB, PAC, or PAC. I will say that in the ASCENT trial, we looked at how many patients got capecitabine. Again, it was 47%. But the PFS was very similar in ASCENT 07 with capecitabine compared to this trial with capecitabine. So it is quite intriguing. Here, 60% of patients received capecitabine as their treatment of physician choice. We were all surprised that only 3% had bone-only disease. Saw the same thing in ASCENT. I think we give capecitabine to patients who have bone-only disease. And the majority of patients, of course, had to have measurable disease, so this was 97% of the population. And a median of 2 lines of prior endocrine therapy, almost 90% prior CDK4/6 inhibitors. And here's the progression-free survival showing a delta of 5.1 months. And just keep in mind, in HER2 low, 13.2-month progression-free survival. So the longest we've ever seen in this setting. And then the PFS in the ultra-low was almost identical here. And the hazard ratio was a little bit higher at 0.78 compared to 0.62. And then, of course, we didn't see an overall survival benefit at this first presentation. We're waiting for longer follow-up. But a fifth of the patients in the control arm had actually received TDXD post-treatment already, again bringing up this issue of sequencing and where we should put our antibody-drug conjugates. We also have seen that the benefit seems to be even greater in patients who had a very short response to first-line endocrine therapy. So first-line time to progression of less than 6 months, you can see this enormous difference in progression-free survival, although the difference is maintained throughout, and then primary and endocrine resistance also a benefit. The safety we'll go through later. Nausea is the most common toxicity from TDXD. Interstitial lung disease exists, and we'll talk more about that in the last talk. Now, lastly, patritumab deruxtecan, presented by Erika Hamilton at ESMO Breast just a few weeks ago, looked at this HER3 DXD targeting HER3, and we've seen HER3 with increased expression in metastatic versus primary tumors, and there were 2 cohorts, Topo1 exatecan naive and pretreated, and the nausea and fatigue most common adverse events. And what you can see here is that patients with a prior antibody-drug conjugate had a very low response rate and a very low PFS, first scan, 2.6 months. Whereas in patients who were naive, had a PFS of 6.8 months. And I think that's really interesting because it does suggest something about sequencing ADCs as well when you have the same payload. So now we have the HERTHENA Breast 04 trial in the first-line setting looking at patritumab deruxtecan in HR-positive disease, and you don't have to be HER2 low or ultra-low in this trial. So lastly, what triggers change to ADCs? I think that we want to use our sequential endocrine therapies. We have a dizzying array of new options that will be available to us. But patients who have primary endocrine resistance or rapid progression with multiple visceral lesions, very low ER, I think are excellent candidates for an ADC upfront as well as true visceral crisis. So let's go on and talk about our discussion questions. What are we going to do in this patient population? So we have a 68-year-old woman who's ER positive, HER2 low, IHC 2+, no amplification, bone mets. She has 2 years of AI ribo, and then she takes elacestrant for ESR1 positive disease for 5 months. Okay. Then she goes on to TDXD with a good response. So the patient says to you, what am I going to do now after my cancer grows on TDXD? What is my next option for treatment? Nadia, what would you tell her?
Well, we use Saxi in this setting after TDXD, and I think there is really not, Giuseppe mentioned it earlier, not much data whether you have to intersect another regular chemotherapy. You could do capecitabine and then go to Saxi, but we really don't know whether that is necessary or not.
Yeah, we don't know anything about sandwiching and the benefits of sandwiching, although we're hoping the rationale between sandwiching, just correct me if I'm wrong, is that you might get back the receptor that you downregulated, right? It's not because you're going to get better response to a drug you become resistant to. We don't know that. So now we have a 61-year-old woman with ER-positive, HER2-low metastatic disease with bone and liver mets who gets letrozole and ribo, but unfortunately progresses at 1 year, and again goes on to TDXD with good response. So does the time on CDK4/6 inhibitor help you decide on second-line therapy? So would you have given this patient another endocrine therapy and targeted agent? Would you have given capecitabine and held TDXD to next? She has progression in bone and liver. Which kind of patient would you consider that for? Bone-only disease, less symptomatic? And if it was IHC 0 and not ultra-low, what would you do? We're facing a patient like that now. Rebecca?
I knew you were going to ask me. So this is a very real case, right? So, I think, we always, when we have seen these patients in our clinic, all the trainees, we'd say 1 year you get with letrozole, 2 years you get with CDK and endocrine therapy. What I'm seeing in my clinical practice is that patients are on adjuvant therapy for so long now that I'm not getting these nice, really long responses in the first-line setting. And so you are seeing these patients that after 1 year, even on combination therapy are progressing. So I have to say, we have data from DB06 that we can use this approach now. But I have to say, just saying they have bone and liver is very different than actually seeing the scan. If someone has a heavy burden of disease and letrozole and ribo or whatever you're giving didn't shrink it, but you got like sort of stabilization, those patients I would put on, TDXD very early on. And, whether 1+ or 2+, for me, it doesn't matter. Is it ultra low? I think many of us would do a more recent biopsy, especially in this scenario, because I think, we know that can change. And I think I'd want to know the most recent biopsy. And I certainly would want to get, to be honest, we try to I know it's wimpy to say you put them on trial, but the bottom line is these are the patients. And I had a patient like this recently that did have a HER2 mutation. And she progressed after 1 year, and then I put her on TDXD, and she's just doing so well. I have another like this that I gave tucatinib, and so I don't know why, but I keep finding HER2 mutations. And I found 2 patients that also had HER3 mutations. So bottom line is, yes, I think if this is a heavy burden of disease, that it didn't shrink at all and you're just getting stability, which is very different from someone who had a really nice response, low burden of disease. In that patient population, I would give another round because I'm not going to miss a window. I'm going to have time. It's very different.
So just a quick response, Erika, what would be your cutoff for going on to second-line endocrine therapy with or without a targeted agent in this patient?
Yeah, I think this patient is purposely in the kind of gray zone. We typically think about a year. She's right at a year, but again, I think we have a fudge factor, like Rebecca said, about kind of, how much disease does she have? Is her progression really more in the bone? Is her progression more in the liver? What's her age? How much progression did she have? So I think we typically think about a year, but I also think what I found on a mutation profile would sway me as well. If I did a mutation profile and I really didn't find anything particularly targetable, that's one thing. If I found a PI3 and I thought I could get some mileage out of, targeting that PI3, that might influence me as well.
And is there a situation where you would ever use capecitabine in the first-line setting? Nadia?
Not really. There are some patients that want to keep on oral therapies and have bone-only disease or so, then I would do that. But I really like to give TDXD once I go to chemo. But we try to sort of give them as many lines of endocrine-based, at least 2 before that, so we're really pushing it, and then I think TDXD is a good agent. But in this patient, if she's symptomatic and we may not have any biomarkers and we really need to act fast, and now she has a good response, I think in such patients, sometimes if you then find markers, you can always go back to an endocrine-based.
And do a maintenance type approach with endocrine therapy and a targeted agent.
It's not a one-way street.
Yeah,
that I would say.
It's a really good point. And no one would give CAPE to any patient, older patient with bone-only disease, maybe? Yeah, I don't know if we see them anymore.
In
we
patients
give them
with
a lot of
bone-only
lines of
disease,
endocrine therapy.
you may consider to do an NGS, and let's assume you will discover a PI3 kinase mutation.
No mutations.
Yes, okay. No mutation.
All right.
You don't mutation, in my opinion, we should give trastuzumab deruxtecan in this patient.
So now we have a 71-year-old woman. We're getting to this case, but except for she's had brain mets. So she has 2+ HER2 low ER-positive disease. She gets her AI and CDK4/6 inhibitor for 20 months, but then has a brain met, probably cerebellar. And, everything else is stable. She had bone mets. They're totally stable. We're not checking ctDNA. How are you going to manage the patient? Are you going to switch? What are you going to do?
This is an HR-positive disease with brain mets. There is a completely different prognosis. In this case, I would switch personally. I would give.
So it's resected and radiated, so she has no active disease anywhere. So you would switch to TDXD here?
Personally, yes.
How about you, Erika?
Oh, I don't know. I think you could go either way on this one. I think I potentially might leave her on her therapy.
And wait for progression.
Yeah, with one isolated brain met, yes. If she had more than one, I think I'd side with Giuseppe.
I saw one patient like this, and a few months after staying on the same therapy, she developed the leptomeningeal disease, and she died.
Yes, but you don't
I had
know
no chance.
that. I just will point out, you don't know that TDXD would have prevented that, and she probably had it when she first presented with the brain met. So I think we do have to be careful of the N of ones, I think, in general, as we move forward. It's all about individualizing and shared decision-making with the individual patient situation. So you can see that, this is a big issue. I do think that we believe that T-DXd is our optimal ADC for HR-positive disease. Anybody disagree with that? In the HER2-0 population, we might try another chemo and then first line and then go to a TROP2 ADC.
Yes.
But in the HER2-low or ultra-low, we're using T-DXd.
But there's one point we haven't talked about. I think there is this data that we lose about 10%, 15% of the patients for each line, not because they die, but because they don't come back for a next line of therapy. So I'll save this till a later line is maybe not such a good approach.
There's been a lot of discussion about that, and it does appear that in triple-negative disease, maybe up to 30% of people don't go on to second-line treatment, and for HR-positive disease, about 20%.
Yeah.
So let's go on and talk about how we're going to use ADCs for localized breast cancer with Nadia.
So, this is an exciting topic because we're using these drugs that we've now established work really well in the metastatic setting, also in the early breast cancer setting. Let me just put my glass here. Thank you. So if you look at the ESMO guidelines, we basically use ADCs already. We use them in the HER2-positive space. And you have now a new approval here in the US since May 15 for the regimens I'm going to show you. And in the triple-negative setting, I think we have some interesting studies going on, and some of them really read out very soon. If you look at where we've come from in the HER2-positive early breast cancer setting with the PCR rates, just with the studies using a single HER2 blockade and then dual HER2 blockade, we now end up with about 60-70% of the patients getting to a PCR, depending on the population we put into the trials. And I think this is something that I'll come back to, which we really have to be careful cross-comparing trials. So the two studies that were presented last year at the ESMO plenary, DB11 and DB05, really established T-DXd now in the early breast cancer setting. DB11 was a 3-arm trial looking at T-DXd THP versus dose-dense anthracyclines, THP versus T-DXd 8 cycles. That arm was closed early because the IDMC felt that the endpoint wouldn't be reached, and there was no recommended post-neoadjuvant treatment that was enforced, so people could actually do what they wanted to, but it was well balanced between the arms. So if you look at the DB11 population, it's by far the highest risk population of all the trials we tend to cross-compare with. Also the TRAIN2 or the NeoCARB study, the incidence is about 70% HR positive, and that what we see. Some of the neoadjuvant trials enriched, though, for more HR negative disease, and it has almost 90% node positive disease. So very, very high risk population, and you've probably seen the PCR rates. There was a statistically significant, I think also clinically meaningful benefit, about 11% difference favoring the T-DXd THP over the dose-dense anthracyclines THP, and in the hormone receptor negative population, 4 out of 5 patients had a PCR. And we just saw data at ESMO Breast by Dr. Pushtai, who showed the RCB scores, and we see in the T-DXd arms we have more RCB 0s and 1s and less RCB 2s. So this is going to impact the survival data, I would say, which we're hoping for next year. So we had an early glimpse at ESMO at the survival. The curves are a bit enlarged, so you can see the difference. About 4% at the 2-year mark, hazard ratio 0.56. The data needs to mature, but I think it's very reassuring that it's going in the right direction. The T-DXd alone arm also didn't do so badly. If we counted all the patients that switched to the standard of care arm as non-PCRs, which gives you an unfavorable 13% difference. If you look what really happens, there's only a 6% difference between a 5-drug regimen with dose-dense anthracyclines and the T-DXd alone arm, and the EFS looks quite similar. So I'm still a big fan, I'll show you in a minute, of the T-DXd monotherapy, but maybe not for the very high-risk population. And the safety actually, and Erika is going to talk more about this, we were pleasantly surprised to see that the ILD rate in this untreated population, where we started at 4 cycles of T-DXd, was only half of that. We know from the metastatic setting, cardiac toxicity was not an issue. And so I think this is really favorable. So we know that from very old data already that the patients with the PCR do well in the HER2-positive setting, and those with the non-PCR don't do so well. So our standard of care for many years has been the Catherine regimen, which compared T-DM1 to trastuzumab. And I just want to point out that there was very minimal requirements. Patients had to have 6 cycles of chemo and 9 weeks of trastuzumab, but everybody basically could get into that trial. And we saw that there was an overall survival difference now published also in the New England Journal of Medicine with almost 5% at 7 years. And what we also saw was that half of the patients in the T-DM1 arm had brain mets as the first site of metastasis. That shows you that we select out really aggressive disease with our good agents now in the early breast cancer setting. And the numbers didn't differ between the two arms. So T-DM1 really didn't prevent brain mets from happening. Then Chuck Geyer presented at ESMO last year in the second plenary talk, the Destiny Breast 05 study. And this was a Catherine-like design, but the population was a bit higher risk. They called it inoperable early breast cancer, so large volume disease. Then any non-PCR would suffice for the study. Or if you had operable early breast cancer, then you had to have a node-positive non-PCR. Germany is a screening country. This is about 30% of our population that way. So if you look at the baseline demographics, you can see that there are these inoperable patients. There were about 50% of them, and 70% had dual HER2 blockade in the early in the neoadjuvant. I just want to point out, because when I presented DB11, everybody was criticizing us for having the anthracycline control arm. But actually, if you look, this is a worldwide study. Half of the patients had an anthracycline in the neoadjuvant setting. So I think that there are some countries that don't use anthracyclines, there are other countries that still use anthracyclines. And I think both works, depends on the risk of the patient. And the study reached its primary endpoint very comfortably, hazard ratio 0.47, and there's almost a 9% difference already at 3 years favoring the T-DXd arm. So this is a substantial improvement over a drug that improves over trastuzumab. So I think this is fascinating data, and they're immediately actionable. After the ESMO meeting, we started to apply on an individual basis for these patients to get T-DXd covered by their insurance. There's also a glimpse at other endpoints, and I think it's interesting to see that numerically there is less brain mets, but Chuck also pointed out in his presentation that we should wait a little because this is very, very early but promising data. I don't want to go into toxicities too much, just mentioning that the ILD rates here in this post-neoadjuvant trial where patients had been exposed to prior chemotherapy are as in the metastatic setting, and cardiac toxicity is not a big issue. So obviously, and I think we're going to discuss this, is now we have the approval May 15 by the FDA for both regimens. So we have to discuss, do we use it preoperatively? There's less toxicity, there's a shorter treatment with T-DXd, and we have very high PCR rates, so we can downscale the surgery, or do we use it in the post-operative setting? That's 14 cycles. But also, this could be a life-saving therapy for those patients that don't have a PCR. Just looking into the future a little, we pioneered very early, about 10 years ago already, T-DM1 in the neoadjuvant setting with fascinating response rates, 40% PCR. And we also showed in our neoadjuvant trial that PCR is the key determinant of survival, even in these de-escalated regimens, and further chemo didn't help. And now we're looking for T-DXd in that setting. The first part of this trial, ADAPT-HER2-4, is already fully recruited. We have 12 weeks of T-DXd versus THP, or 6 6 cycles of TDXT versus TCBHP. Hopefully we can present the data later this year. And we also looked at TDXT in the standard arm patients with a non-PCR. So if you want a DB05 for this stage 1 and 2 regimen, cancer patients. And we now amended the trial also to look at the sequence, either 6 weeks or 12 weeks of THP after that in these early stage patients to sort of complement the DB11 data. And I think it's going to be really, really interesting. So just a quick glimpse in the triple negative setting. We don't use ADCs here as a standard of care yet, but I think they're coming. This is an approach we're taking also for the stage 1. There is no standard in stage 1 triple negative. You can give chemotherapy, so we're using sacituzumab plus minus pembrolizumab. If the patients have a good clinical response, then we take them to surgery. If they don't have a good clinical response after the 12 weeks, we give them another 2 cycles and then take them to surgery. And another approach to sort of look at integrating ADCs, but also trying to de-escalate patients who have a very good response after the first part of the keynote regimen. They get taken to surgery, and if they have a PCR, they don't need further treatment. But in the lower part, you can see that patients who don't have a good clinical response after the taxane carboplatin regimen will randomize against sacituzumab versus the anthracycline-containing regimen here. And what else is coming? We have a neoadjuvant trial with the SAC-TMT regimen. It's the TroFuse study that's currently ongoing. And we have the TROPION-Breast04 study, which looks at Dato-DXd plus Durva, based on the wonderful data that we've seen in the metastatic setting, also in the neoadjuvant setting. And lastly, we also have some trials looking at ADCs after non-PCR with IO in the early triple negative. The Saskia trial has been completed for a while, also included the HR-positive disease, and we're looking for the results pretty soon. We have the TROPION-Breast03, which looked at non-PCR with a Dato regimen plus minus Durva versus investigator's choice. And then we have the Ascendo-5 study, which is looking at sacituzumab plus pembrolizumab versus standard of care. So a lot of exciting data to come in triple negative, and I'm sure some of these studies will read out positive and will be practice changing immediately. Thank you.
All right, so we're going to talk about some cases and how we put these in. I mean, this is a hugely controversial area, I think, where everybody has a slightly different take on it. So 54-year-old lady who has locally advanced HER2-positive, ER-negative stage 3 disease. So what do you do in this situation? Are you going to give TDXT a la DB11? Are you going to give THP followed by TDXT? Or are you going to give TCHP and then treat patients out back as in DB05? So let's see. Nadia, do you want to answer that first?
Yeah, of course I'm camp DB11, I think the 4 cycles. And she has an 83% probability of getting a PCR. That's 4 out of 5 patients. And I think we can do less surgery. It's less traumatizing if we have a PCR, and we can de-escalate the post-neoadjuvant therapy. So I would start with TDXT.
And so, Rebecca, when would you not?
So first of all, I do agree with Nadia. I'm more in the DB11 camp, meaning that I think we get really high, PCR rates. For this kind of patient, I am actually not a big fan of TCHP. I actually find it very toxic. In fact, TDXD followed by THP is actually much better tolerated and had higher PCR rates. So especially in an ER-negative, HER2-positive. So bottom line is, who would I not do this for? Well, I guess someone who might be less aggressive, have potentially get a good response with THP. And I think we're looking at a lot of studies looking at who those patients we can stop. So if it's smaller and clinically node negative, then I probably would obviously do that. But I think what's amazing is that, 14 cycles in the adjuvant setting versus trying to go for it up front. We had a lot of patients on study, and trying to give adjuvant TDXD, I'll be honest, is much more challenging, repeating scans, and they've had radiation, and what's this, and what's that. So I think the only challenge is, when you're giving TDXD neoadjuvantly and they don't have a PCR, then what do you do? So I think.
So let's go on to that next. Hold on.
Yes.
So nobody talk until I call them. So so now we got a 49-year-old woman who has this HER2 positive, HR negative IDC. So she got THP. She has a lot of residual disease. And now she could get DB05. I think we all agreed this trial was practice changing. That's what we would do.
Yes.
But what if you did what Rebecca just brought up, gave her DB11 type treatment, and she now has residual disease, HR negative. So would you try more disease? Would it depend on how well the patient responded? Would you give TDM1? What would you do, Erika?
I'd give TDM1 for residual disease.
And any thought about that? I mean, so let's say
the question is whether if you have residual disease after the Destiny 11. This is the question.
Mm-hmm. Right.
Correct.
So the patient got Destiny Breast 11. So let me just ask Erika this other part of the question. So TDM1 alone, right? So you're just going to give TDM1. So if she responded to TDXD, but still has residual disease in breast, negative nodes, there's never a situation where you would give TDXD again.
I mean, there is a situation. So if she had a very large tumor and she had just a tiny bit of disease left, I thought, she just needed an extra cycle or two maybe. But if she had like a centimeter of residual disease, I really thought she kind of had an inadequate response, I'd switch to TDM1.
Okay, so I'm going to ask I'm going to wait to get to this, but I'm going to ask Giuseppe, is that what you would do also? If you had a patient at DB11, they got 4 TDXD followed by THP, and they have residual disease, what are you doing post-op?
So if you had a response on the first 4th course, I would consider to reintroduce trastuzumab deruxtecan in the post-neoadjuvant. No data, absolutely no data to do this, but we don't have data on TDM1 post-TDXD neoadjuvant. But assuming that you had a response, there is this opportunity because another way to use TDXD, if you start with TCHP, let's assume after 4 cycles you don't have a response. Why not introducing trastuzumab deruxtecan as an adaptive strategy in order to maximize the probability?
So would you, instead of using DB11 type approach with the patient we had before, give THP and in patient still has demonstrable disease, then give TDXD?
Yes, you can do this. Why not?
Would you prefer that regimen? Any comment, Nadia?
Yeah, I just love the TDXD in the untreated patients because the toxicity is so good, and it's I don't know whether it's going to be the same if I start with chemotherapy. That's my thought. But I would completely agree with my colleagues. If a patient has just a minimal residual tumor burden, I would continue with TDXD, and that's exactly why we built this into the amendment of the adapter to 4 in order to get that data, whether by just having a little bit more cycles, we can actually help the patients.
Should we all vote of whether we're DB11 or DB5?
I know, it's funny because I was talking to Sarah Herbert, who's like solidly DB05.
I know.
So I think, it's interesting, and some people are more switch the order and give THP first, but I will say, you then have to deal with hair loss and peripheral neuropathy and prevention of such things, whereas you don't. You give TDXT first, but then you're still giving THP. So it's a hard decision. You certainly could vote, but I think our table seems to be more in the DB11 approach than either way, either order, rather than DB05 first. And then using TDXT 14 cycles afterwards in patients with residual disease, I think is now a standard of care. And one question that came up was if patients, has residual disease, they got TCHP or THP for that matter, you're going to give TDXT. Are you going to hold off on the TDXT until you're done with radiation, or are you going to start both simultaneously?
We have the data we can give simultaneously. So in the Destiny 5, there is a cohort of patients who received the concurrent trastuzumab deruxtecan and radiation therapy with no increase in terms of rate of ILD and no additional toxicity. So we can do also concurrently.
Anybody have any concern about that? We saw some data today also, not just that there wasn't an increase in ILD, which we had already seen from data Sybil Leubel presented last San Antonio, but also we saw data that if you got ILD from one, you didn't have more radiation pneumonitis and the reverse, which was very encouraging, I think, very different mechanism and easier to differentiate. So would you give them simultaneously, Erika?
I would. It looked like there really was no difference between concurrent or sequential, so I would go ahead.
I think it's kind of nice to finish earlier than later. So now we have a patient who has residual disease and is progressing on post-neoadjuvant TDXD with brain metastases. And, what would you do in this situation? What's the optimal next treatment? And then what about a patient who now we're going to have people who get TDXD, and hopefully very few of them will develop metastatic disease subsequently. What are we going to do in that setting? Now, obviously, there are new drugs that are being tested, zanidatamab, biparatopic antibody. We're testing TDM1 and tucatinib in the post-neoadjuvant setting. There will be lots of different data coming up that may influence this in the future. But Rebecca, what would you do in this situation?
So, I think... just looking at the times, you didn't put in the...
So the
We don't know
patient
the
has,
time, yes.
if you have
Progression
progressed
during
on,
treatment.
you suddenly develop a brain met, or what are you going to give the patient next?
I'd call you.
You'd send me a WhatsApp.
Yeah. No, I think, at this point, so basically the patient, so she's got progression in breast. I think, you'd want to restage and look and see if she's got other disease elsewhere. Because obviously I think that's going to factor in. So she's progressing. She's got new brain mets despite, so while she's on TDXD, I'm presuming. So, I would call Erika then because Erika is our tucatinib expert. So I've actually had patients like this who have actually seen quite dramatic responses in brain with tucatinib for prolonged periods of time. So I think at this point you'd have to say she has CNS disease and she's progressed on what we hoped was curative intent. Thankfully, we don't see that often, but I have had one or two.
That's great. And I think, the idea about re-challenging with TDXD, I think it really has to do with how long a duration it is since you stopped. More than a year is our key. We have no idea if it's the right one, but that's what we use.
I think the other thing is, though, I have been doing a lot of biopsying, and I think we've seen a lot of data.
They still hurt you.
Yeah, I think, and I've been really surprised along the way that, doing biopsies can be very helpful in guiding what you do next. No, especially if you want to give TDM1, because we did some of the earliest data with TDM1, and basically depending on how the FISH ratio is, if it's very high, they can respond very nicely to TDM1, and it's well tolerated. But if the FISH ratio is quite low, this is truly, there's no bystander effect. So giving TDM1 when you have lots of HER2 does not work.
You might not choose that drug. So now we have a patient with TNBC. So she has bad disease, locally advanced, and is treated with Keynote-522 and has residual invasive disease at surgery. What are you going to give her today in the post-neoadjuvant setting, Erika?
Yeah, I think that the questions here at the bottom are already giving away our answer. I think, you would try to get her on any clinical trial. You could get her access to an antibody-drug conjugate. I think, standard of care would really be capecitabine with continuing her Pembro. But, I think we all recognize that patients still need more. So the TROP2 antibody-drug conjugates are in clinical trials right now. So I would try to get her on a clinical trial.
But if you couldn't, she comes to you, she's gotten 5 doses of Pembro already through her radiation. What are you going to do with her?
I'd give her capecitabine.
Okay, and complete
Don't forget the
Pembro.
BRCA testing, though.
Yes, she had BRCA testing. In the U.S., everybody does, so, but it's a really good point. So our last quick case is 86-year-old woman with TNBC. She's open to an ADC. What would you do in this situation? I'm going to ask Rebecca because I know that she has run into this kind of situation because we've talked about it a lot. So what would you do?
Great question. So I guess, what you're asking for us for is, we've proposed some interesting studies to look at ADCs in our older patients, and certainly, we have a geriatric oncology nurse who comes and assesses these patients because she's 86, So I think, if you just go back to the case, so I think you have a couple options. So one is Go back to the case.
I think we have to move
so
on.
So she is not amenable to surgery, but it's locally advanced. So I had a patient like this on Dado, actually, who, it's every 3 weeks. The patient tolerated it extremely well. As you know from the Tropiano-2, none of the patients stopped because of stomatitis. Several months in is when they get the eye talk. So, this is someone who probably would tolerate it quite well. And I think you'd get local control. So this is for quality of life as well as increasing. And so I think, as I said, I had a very nice retired medical secretary, who was exactly like this. So maybe you remember that patient.
Yeah. And I think that you can vary the dose and the frequency of dosing, the schedule, and to make it more tolerable for our elderly patients. So now we're going to move on to, I think, a critical question here, tolerability questions with ADCs.
Perfect. So we're going to go through some tolerability of the antibody-drug conjugate. This is last, not because it's least important, but I think everyone else has already convinced you that we should be using these antibody-drug conjugates, whether we're talking about metastatic or early disease, and they've really quantified the incidence of the side effects through these various clinical trials, and we're going to be talking about how to manage them. I'm going to really skip this slide because I think we've already gone through these. I guess the one addition is that we really still have TDM1, which we haven't talked about a lot tonight, but this is kind of our oldest antibody-drug conjugate at this point. And now we have TDXD, sacituzumab, and Dato that have joined it. So this is the most attractive diagram ever. This poor woman has every side effect known to man from the antibody-drug conjugates. But it's really just to remember the different body systems that the antibody-drug conjugates can affect. So we have ocular. This is predominantly what we think about from datopotamab deruxtecan. Oral in terms of mucositis, also from datopotamab. Respiratory, this is ILD, and we tend to think about this most common really with TDXD, and then over on the right, hematologic. We think about that with sacituzumab govitecan with neutropenia, but also remember that we often see thrombocytopenia with TDM1. And then GI, we can think about that in terms of nausea with the deruxtecan payloads, most common really with trastuzumab deruxtecan, but we can also think about lower GI side effects with diarrhea from sacituzumab govitecan. And then I show this not because I want you to memorize this table, but I think it's really important because I think as oncologists, we like to try to make things simple, and we try to file these adverse events into buckets. And so it's very tempting to kind of say, oh, well, this is an antibody-drug conjugate, so antibody-drug conjugates like tyrosine kinase inhibitors should have similar side effects. And we can't lump all of these antibody-drug conjugates in one bucket and say that they have similar side effects. They really are quite unique drugs, and depending on which antibody-drug conjugate you're using, you're going to encounter very different side effects. Take even the two TROP2 antibody-drug conjugates, and they have a very different side effect profile. So really don't, lump these together. So let's go through hematologic toxicities. I think most of often we're thinking about neutropenia with sacituzumab govitecan. And again, I think most of us use a prophylactic growth factor for sacituzumab govitecan. This can be a little bit tricky, again, because of the day 1, day 8 administration. So we can't use a pegylated growth factor between day 1, day 8. And so most of the time, and I think most of us are using a pegylated formulation after day 8, really trying to drive that white blood cell count up, getting it high so it lasts through the next cycle, and then giving a pegylated growth factor after day 8 in the next cycle. Again, we do see some neutropenia with TDXD. That tends to be a lower grade. We do not need growth factor with that. And we also can see certainly thrombocytopenia with TDM1. In terms of other heme toxicity, we really can see kind of low-grade anemia with most of these antibody-drug conjugates. This doesn't tend to be a major problem, but certainly we need to watch out for this, and then thrombocytopenia as well. In terms of GI toxicity, I think nausea is really the most important to remember for TDXD, and this is now considered highly emetogenic. And so at least in my clinic, we're standardly using a 3-drug antiemetic regimen in a prophylactic fashion. So this is an NK1, a 5-HT3, and dexamethasone, and we're using all 3 of these in a prophylactic fashion. TDXD is not a drug that you want to wait for people to report nausea before you give them prophylactic antiemetics. You're going to get in trouble if you do that. We also have stolen a tip from the GI literature around olanzapine. I personally don't start olanzapine up front, but that is my go-to if anyone is having nausea after this 3-drug prophylactic antiemetic regimen. I give olanzapine at the lowest dose, 2.5 milligrams once at night, and this can be really effective in controlling nausea. I tend to see more of this, particularly in my younger patients, actually, but it can be really helpful with delayed nausea that a lot of people with TDXD can see. I think this slide in some ways is a little bit less helpful. Obviously, the common things about nausea and vomiting, to be careful about what they eat smaller meals, et cetera. But really, I think really supporting with medications is the key here. In terms of management of diarrhea, sacituzumab govitecan, I think, is a little bit funny in terms of this, as opposed to TKI diarrhea, where really universally everyone is going to have some diarrhea. It's just a question of how much diarrhea they're going to have. I find SASI diarrhea to be a bit binary. People either have diarrhea and it's a bit of a struggle for them. It can be, pretty significant diarrhea, or some patients don't have diarrhea at all. And so I don't use a prophylactic antidiarrheal for that reason, because if you do, some patients actually get into trouble with constipation. And so I make sure that patients have loperamide at home, but they really only start that loperamide if they do get into trouble with diarrhea. Make sure that you're educating them that they take 2 at the first loose stool, 1 every subsequent loose stool. If they're still struggling after that, we can use tincture of opium, we can use atropine, we can use dose reductions. But really, I think the other thing that helps in our clinic is we have a nurse call them a few days after their first dose, check in, make sure that they're doing well. And frankly, I think that day 8 visit also helps a lot, that they're coming into our clinic to see how they're doing as well. In terms of mucositis, this is what we're worried about more with Dato-DXd. We've already talked about this a little bit. I think this slide is helpful because you can see tropion pan-tumor-01, which was really our first experience with Dato-DXd, then tropion breast-01, and then on the bottom left, tropion breast-02. And you can see that each time we were doing a little bit better with stomatitis, and I think this really came from the fact that we were learning that this was a significant side effect, and we were doing a little bit better job of really teaching our patients about it and using steroid mouthwash in a prophylactic fashion. So our steroid-containing mouthwash, unfortunately, in some places across the world, this can be a little bit hard to find. And sometimes, even in the United States, depending on the month and the area, sometimes it can be hard to find as well. But really recommending patients to use this 4 times a day at least. And I have to be sometimes, a little bit firm and a tiny bit scary, just telling my patients, look, I need you to use this prophylactic mouthwash. You may think after the first week or 2, hey, I'm not going to be a patient that's going to get this side effect and want to stop it, but don't stop it. Because if you do get the mouth sores, it can be hard to get rid of. So really keep up with this. Preventing it is really the best way to control this side effect. And I have luckily, knock on wood, for my patients that have kept up with the prophylactic mouthwash, not encountered any significant stomatitis. But when patients get the stomatitis, again, it's not a side effect that resolves super quickly, and patients can be hospitalized with dehydration, really inability to eat, and so it's not something that you want to take lightly. In terms of ocular toxicities, luckily, I think as compared to the gynecologic world, we came out a little bit lucky here. Datopotamab deruxtecan is the one that we really think about more in terms of the ocular toxicities. But really, in my experience, it's a bit more of a dry eye. We can see keratitis, so we do recommend baseline eye exam. We can have ophthalmologists help us, and even actually optometrist. It doesn't necessarily have to be an ophthalmologist for a baseline eye exam. But as opposed to a mirvetuximab, where we're getting into kind of more serious eye toxicity, this really tends to be kind of more surface events and a little bit less worrisome than some of the other antibody-drug conjugates. In terms of ILD pneumonitis, I think we've already talked about this, and I've already broken the rules here, but let's go through it anyway. In terms of drug-induced ILD pneumonitis, we've really tried to be able to predict who's going to get this and who's at risk, and this is tricky. We have been able to establish that our patients of Japanese ethnicity unfortunately do look like they're at higher risk to get ILD pneumonitis, but it's hard really to tease out otherwise who's going to get it and who's not. It also appears that ILD risk is higher within the first year of receiving therapy, and it does drop down afterwards. But I will say that my only patient that's had significant grade 3 ILD, luckily I've not had grade 5 ILD, again, I'll knock on wood here, had it outside of the first year, so there's no fast rule to when somebody's going to get ILD. I think one of the big things is really educating our patients about ILD. If you think about, living in 2026 with viral illnesses, with bronchitis, with asthma, is the reality is that your patient may not come to you when they have ILD. They may walk into a CVS or a doc in the box or their primary care physician, and it may not automatically be recognized that this is ILD. They may think that they have bronchitis or a viral illness. So really letting them know that if they have any pulmonary symptoms, if they have cough, if they have shortness of breath while carrying laundry up their stairs, that you want to hear about that. My patient that had grade 3 ILD, that's how she determined this, is that she became short of breath carrying laundry up the stairs only 2 weeks after her last CT scan, which was completely clear, by the way. So I think it's really important for us to educate our patients about this and have them be their best advocate. The other thing about ILD, particularly with trastuzumab deruxtecan, is it's really making us not want to push out their scan interval. For a therapy that patients may be on for quite some time, a lot of times we kind of let patients stretch their scan interval. But again, because we're stopping the therapy and not restarting at grade 2, we're really wanting to find these cases at grade 1 when it's asymptomatic. And so that's really keeping me to keep scans at every 9 weeks so I can find this, intervene, get rid of it, and get the patient back on drug before it becomes symptomatic. So again, these are the recommendations. Even for grade 1, we're stopping the drug. This is very different than what we see with checkpoint inhibitors. For example, I typically start steroids even for grade 1 because I'm wanting to clear it up, get the patient back on treatment. And again, for symptomatic ILT grade 2 or greater, we're supposed to discontinue and not restart. So these are just the 5 S's, again, screening, scan, suspending treatment, and how important steroids early are for treatment of ILD. So again, ADC, AEs, I think Nadia went through this quite well in terms of DB11 and DB05. I think patient selection based on risk of recurrence with DB11 versus DB05 is really key, especially for DB05. We're going to need to be doing CT scans in the adjuvant setting to monitor our patients for ILD, and I think we await more data on DB11 in the curative setting for event-free survival as well.
Okay, thanks very much. So I think that, these are all really helpful suggestions. Rather than going through some of these cases, we'll see if we have time towards the moment. But there were some additional questions that came in also from the audience. One is that if you had DB05, if you were planning to give TDXT post-op, right? And you're starting out, would you give carboplatin given the neocarb, or would you avoid carboplatin? Giuseppe?
This concept of omitting carboplatin based on a study, on a single study performed in China, for me is really very complex. So personally, I would give carboplatin, to be honest, yes.
Anybody else disagree? If you had enough disease that you were thinking of post-neoadjuvant, most people give it. Now, I will say we do use THP for patients who have really small tumors in the neoadjuvant setting, and this may be very effective therapy. I think for a patient who has a T1C node negative or T2 node negative tumor, THP is not an unreasonable approach.
This is another case, of course.
Not the patients who are candidates in this situation. Yes. So the other areas that I think that Would you biopsy patients? I know you biopsy. People have surgery, they have residual disease. Do you always retest for HER2, and how does that influence your decisions about treatment? Nadia?
We routinely retest the non-PCR specimen. There is data from the Catherine trial that you should still give TDM1. This is, I think, 70 patients, and there was just no recurrence in the TDM1 arm, but a couple of recurrences in the trastuzumab arm. And I think with TDXD, it's even less of a problem because we know it nicely works also in HER2 low.
And I think that's a really important point, is that may be part of the benefit of TDXD in this situation, is that even if you have heterogeneity, you're going to see effectiveness here. And are you concerned, we talked about giving TDM1 after TDXD if you had given a DB11 and had residual disease. The question is that, if you lose expression with HER2, if TDXD downregulates the receptor, does that worry you at all?
I mean, I think... Sure, it worries us just because we don't have great prospective data there. In DB11, the majority of patients with residual disease did get TDM1 on that trial. So, I think when we look at the data set from DB11, I think we can feel confident that, the patients did receive TDM1. There are some trials kind of ongoing, really kind of trying to quantify the loss of HER2. It looks like that's probably very transient and not something that persists. So I'm not overly worried about it, no.
Yeah, it does seem as though the receptor recycles itself fairly rapidly, so that's not really an issue. And I think another question I'll just answer, which is, if you gave DB11 a residual disease and you're going to give TDXD post-op, you'll have given 18 cycles of TDXD. Is that too many? Think about DB09 and DB03. We're giving tons of TDXD. I gave 4 years on DB01. I don't think we care so much about that. There is more ILD the more cycles you give. We've seen that now, and then it sort of plateaus out. So rather than reading the case, I'm going to ask you, Erika, if a patient has radiation pneumonitis, do you have any concerns about giving TDXD?
I think in anyone that has a history of pneumonitis, I think that does give you a little bit more pause with TDXD. So yes, I think it depends a little bit on when that occurred, how significant was the radiation pneumonitis. So yes.
Although the data that was presented from DB05 earlier today, I can't remember which day it is anymore, was suggested that prior radiation pneumonitis didn't predict more ILD, which was interesting. Yeah. It's from one study, right? Yeah. So, but would you monitor that patient more closely?
I think we're already monitoring
very
ILD
closely.
Pretty closely as the insurers will allow us to
right.
with scans every 9 weeks.
So now, if you have diarrhea from SG and neutropenia, who do you give growth factors up front? Or, I'm sure everybody goes home with loperamide in their pocket, but does anybody checking for UGT1A1 polymorphisms, et cetera? Rebecca?
So great question. So in an Asian context, to be honest, we see a lot more myelosuppression, not necessarily diarrhea. We aren't routinely looking, but I would say we would never give sacituzumab without a dose reduction or mandatory GCSF, and then obviously we're checking the counts in real life, and especially in patients that have just received Keynote 522, there really are, the myelosuppression is very real. And it's not
you would always give growth factor?
Always.
And you send them home with loperamide to call you if they have diarrhea?
Yeah, and then we strongly educate, because I think I'm of the day when irinotecan first came out, and I had to convince the ICU docs to give them loperamide because they were like, "Oh, we got to prove it's not infective." And when we had irinotecan, so I think we do a lot of teaching around that, because I think that's where a lot of the that we did see some deaths on treatment with SASI at one point. So I think we need to make sure that people are educated about this is not infectious diarrhea. They have to make sure that you control that diarrhea, and they're coming in day 8, so you got to check their counts.
And do people give the long-acting growth factor after day 8 for SG more commonly, or do you give short-acting?
Good question.
I watch, to be honest. I find what's really interesting is patients are so heterogeneous in their tolerability. Like some people, I start with giving at least 2 days with each cycle. Some people, that's all they need. Other patients, you really want to get the day 8. I find the fatigue limits my ability to keep with the same dose, to be honest with you, or other side effects. So I'm having to dose reduce a little bit. Occasionally, I've done your day 8 approach. I know a lot of my colleagues have day 1 and 15.
Works very well. We give, after day 8, the long-acting growth factor.
Most of my patients don't live super close to our center, so day 8 works.
Yeah, you can even give them the on-body device. It works really well. And so you talked some about the stomatitis with Dato-DXd, Erika. So are you giving everybody steroid mouthwash and eye drops for Dato? I think the label for Dato, which isn't finalized, I guess it's not out yet, but will suggest regular ophthalmology or optometry visits every 3 cycles or something. Ad infinitum, which I'm not sure any of us are going to do if everybody's fine after the 3 visits, But what do you do?
I do. I give everyone a steroid. I do not give everyone eye drops. I do give everyone a baseline eye exam. I agree with you. I think that I'm probably going to start tapering those eye exams off if they're doing okay.
I think it's just hard to coordinate.
Yeah.
Last comment.
Yeah, no, I think what's really interesting, like hearing the ILD discussion. So with ILD, you don't get a warning sometimes, right? You comes right away. The one thing about the eye stuff is that, what we're seeing is that, usually it takes about, 2 to 3 months to see it, first of all, but you get a warning. There's a natural history where they will have dry eyes, they'll have increasing symptoms, which will prompt you to get that eye exam, which is a bit different than ILD where you don't get any warning. So, you are going to have a warning and you need to have a relationship. Most of the time it's grade 1 or 2. I find the funny thing is all my patients that I was screening that were had contact lenses had grade 1 keratitis, and I was like, oh, that's horrible. But the eye doctor would say, no, that's actually quite normal.
Everybody
they're supposed to not wear their contact lenses, but we tell them not to wear it like maybe the day before, a day after or something, because it's very hard not to wear them. But I think the idea behind the FDA's recommendation is that if you found the little microvesicles early, you could use the low-potency steroid eye drops for 3 days, and it would be better. So there is some rationale behind it, and I think you just have to make individual decisions there. I have to say I also give olanzapine to 100% of people when they start TDXT and then taper off the 2.5 milligrams, because in the world of nausea, it's better not to have it and then taper down than to have it and treat it because of their psychological issues. Now, we've come to the end of our discussion here and our time. Thank you so much for your attention, for the questions for people who put it in, and to the faculty for excellent talks and discussion, really very nice. And of course, to the staff of RTP putting together a fabulous program. Thanks.